Well, I appreciate you giving me the opportunity to talk to you all tonight. This is Chad Eckert. He's an engineer that works with J&J and Ethicon and has helped develop a model that will hopefully help us better understand what the causes of air leaks are in surgery of the chest and some of the devices and how they can impact and reduce this complication. And my job tonight is to really shed some light on the clinical aspects of air leaks and how it impacts us and our patients. Start the slides, and I'm just going to give a sort of a clinical overview, and then I'll let Chad, who's much smarter than I am, talk about this model that hopefully in the future we can use going forward to help newer surgeons learn and understand the causes of air leaks. So postoperative air leaks, as most of the surgeons in this room know, is probably one of the, it's not a major complication, but it's probably the most common problem in thoracic surgery that keep our patients in the hospital for a long period of time. And what we do at the time of surgery and after the time of surgery can influence how the patient recovers from that air leak. Most of our air leaks are clinically insignificant. However, there's a significant percentage, at least 10%, that are clinically significant and prolong the stay of our patients in the hospital. And generally these are associated with worse outcomes. There tends to be more postoperative complications in these patients. It certainly prolongs the stay, and if the stay is prolonged and the interventions are increased, the higher the cost to take care of these patients. So the predictors, we are all familiar with some predictors of air leaks. The incidence, duration of postoperative air leaks are not necessarily a consequence of surgical variables. I do believe that there are some surgical variables that influence this, but not all of them. And there are some characteristics within our patients that help identify which patients are likely to have air leaks and which patients are not, such as the classic COPD patient or the emphysematous patient. Those that have a number of adhesions or redo surgery in patients, upper lobectomies or bilobectomies where you end up having a risk of a space defect has a higher likelihood of an air leak. And then patients with diabetes, patients on corticosteroids, patients who are smokers and have previous infections such as TB, all can be increased risk factors for air leaks. So how does this impact our patients? How does this impact the healthcare system as a whole? And I bring your attention to this MedPAR study, or this analysis that was gathered from the CMS database. And they looked at patients that are high risk for air leaks, those that have lobectomies and those that have lung volume reduction surgery. And we know that if the air leak prolongs, particularly longer than 7 days, this increases the morbidity, increases the necessary interventions to deal with these air leaks, and then thus increases the cost. So they go into this detailed analysis even further and divide these patients who've had lung volume reduction, segmentectomy, or lobectomy into separate groups. Those that have group A, which is no air leak, and group B that have an air leak, okay? And then they divide the group B into two separate groups with the patients who have an air leak that lasts for less than 7 days, and then also a group that has an air leak greater than 7 days. And you can see the financial impact to the healthcare system as a whole. You can see that patients who have an air leak greater than 7 days, there's an increased cost of almost $115,000. So it's a substantial impact financially to the healthcare system and our patients' care as a whole. So how can we address this and hopefully reduce this? And I'm going to just briefly talk about a little bit of the treatment and what my philosophy is around air leaks. But I think the most we can do is use good surgical practice to influence whether the air leak is going to be likely or not. And I think best practices at the time of surgery is your best hope to have a reduced air leak. But there are alternatives after you've operated and you find a patient who has an air leak. What we're hoping to do with this model is help understand the causes of air leaks at the time of surgery, how these products that companies offer us to staple the lung and seal the lung impact air leaks. And that's what I'm going to ask Chad Eckert to talk to you about, and where this model is going forward in the future to help younger surgeons understand where these come from and what we can do about them as we go forward. And I'm not going to go into all the necessary treatments that we have available to us as surgeons once we identify a patient with a prolonged ear leak, because I think we all sort of understand what's out there, and I don't want to take the time to go through that. But I'll let Chad, who's got a lot more complicated presentation to give you, so I think he needs a little bit more time than me. Chad?
And you have some great summaries up here. Etiology of air leaks is multifactorial, and so we have really been trying to design models to better understand specific causes that are attributed to air leaks. And there's an importance of how the device interacts with tissue to influence air leak incidence and magnitude. And that's something also that we have an interest in from the device standpoint. So as Dr. Beluski mentioned, my name is Chad Eckert. I am a principal engineer from the Research and Development Group at Ethicon in Cincinnati. And much of my focus has been on developing new, more clinically relevant models, performing experiments with these models, and from these experiments gaining insights that's helping us to better design products. And that's been an incredible focus of ours. And so I'm excited tonight to share our ongoing journey in a new lung model that we've developed, some of the insights we've gained from this model, not only to inform our future products, but actually has helped us to give some more insight into the intentional design of current products. At the very least, I hope at the end of this talk, the one thing I'd ask you to take away is perhaps a better appreciation for Johnson & Johnson's commitment to understanding the science behind complications that you as surgeons and doctors see in your patients with the ultimate goal of improving patient outcomes. And really that improved patient outcome is the heart of our focus, and that's a goal that we believe we share with you. It starts with the patient, driving outcomes, and from that, we intentionally design devices with a tissue-specific response in mind. And we know that we can't stop there. This then informs the experiments we need to be doing to provide you the evidence to show how these designs are influencing outcomes. And of course, this is all cyclical because that information feeds back into our design process. Dr. Beluski mentioned there are a variety of factors that influence air leaks. When we talk with thoracic surgeons, we often hear factors like tension, lack of apposition, manipulation, dissection of tissue, disease all playing a role. But as you know best, because the standard of care is not to reoperate, it's very difficult to attribute any one cause to any one observed air leak. And in fact, it becomes even more difficult to specifically attribute an air leak to a location on a staple line or adjacent to a staple line in all those cases. Further complicating this is the difficulty in limitations of some of the benchtop and preclinical models that currently exist. Those models are great for certain experiments, but become more problematic when we're interested in disease responses, when we're interested in perioperative ventilation, lung mechanics, differences in how the patient is breathing in the OR versus bedside, coughing, deep breathing, a number of factors. So for us, we saw that there was a need really to drive towards a more clinically relevant model to better mimic lung mechanics, not only to allow us to assess our current devices, but also make inform new solutions I had mentioned previously. And specifically, the research questions which we had great interest was what contributes to the cause and worsening of air leaks? What role does pressure play? It was a hypothesis of ours that pressure may influence air leaks. And finally, how does the device influence the occurrence and magnitude of leaks? My background is tissue engineering and tissue mechanics, and I was at an Artificial Organs Conference a few years ago, and happened to sit into a session that I didn't intend to. Very serendipitously met Dr. Harold Ott, who's a brilliant researcher, thoracic surgeon at the Mass General Hospital, working on organ regeneration. And him and I quickly recognized the synergies in our efforts, started a collaboration. And the result of that is a lung model that I'm talking tonight about, in a simplified schematic of that on the screen. And so as you can see in the Unfortunately, I only have one pointer, so I'll try to point to the far screen. You see in the model, the simplified schematic, we have a ventilator, which allows us to impose mechanical ventilation as would occur similar to the OR. We have a piston, and as that piston oscillates, it simulates a diaphragm, which induces the negative pressure to open the lungs up in a completely different mechanism than pushing the air in. This is obvious, but the chamber is clear, and that was essential for us because we wanted to be able to visualize the lungs, visualize the staple lines, where leaks were occurring, and so we can accurately capture those leaks. And then finally, we have a system that allows us to isolate leaks from specific locations, capture those leaks, and quantify them. So as engineers, we like to attribute numbers to things that we can then quantify the magnitude of those leaks. And so from this, we are able to evaluate the incidence, the volume, and the source of air leaks from staple lines or other types of interactions with the tissue. Our goal all along with this work was never to do it in isolation, but to work with thoracic surgeons. Our models are only as good as the input that helps drive the creation. So we worked with 2 thoracic surgeons, Dr. Harold Ott, I mentioned, Dr. Jim Waddell at Wake Forest, and they helped really guide and inform this model. We also wanted to go through the peer review process. We wanted to share this work, we wanted to disseminate this work, and importantly, have it tested through the peer review process. So I'm proud to say that this was published last year, one of the top biomedical engineering journals, open access. If anyone was interested, please, this research can be downloaded for free. We talked in that publication about the model, about the features of that model, why they were built the way they were. We also did an experiment where we created a leak with a needle, and then we tracked that leak as we went through what we call a perioperative ventilation strategy. Guided by one of the anesthesiologists at Mass General, we came up with what patients would see from a ventilation standpoint as they are in the OR, being operated on, mechanical ventilation through reversal of the paralytics, emergence, and finally extubation, even deep breathing and coughing. And we were able to track that leak as we went through those breathing phases. In addition, I'm not going to talk about this tonight, but certainly would love to talk if anyone's interested. Our model allows us to perfuse the tissue, so I had some homemade Perfex that I created, and we were able to observe gas exchange, glucose utilization, lactate generation, so we're actually seeing a metabolic response that this tissue is living, fluorine gas exchange. I'm not sure if the folks here have utilized electrical impedance tomography, but we have a mechanism by which we can look at the distribution of gas in the lungs to ensure that we have proper ventilation. But really the focus of this study was to look at how those leaks evolved with different breathing modalities. And for us, this was very surprising, probably the key result from the experiments in the study. And that is, as we took those lungs through this breathing scheme, we saw the leaks increase substantially when we transitioned from mechanical ventilation, the positive pressure pushing air in, to the negative pressure modality, simulating the patient breathing on their own in the room. And it's important to point out that the tidal volume was kept the same. So we weren't introducing more air. We were merely just changing the mechanism by which that air was being moved into the lungs, positive versus negative pressure. This is an interesting slide because we presented this now to maybe 1,000 surgeons, and it's been pretty evenly split, 50-50, on surgeons that say, I 100% see this and agree with this, and surgeons that say, I 100% disagree with this, I don't see this. And for us, it's been very interesting to hear pretty even mix of that. And anytime I have a surgeon with me, I love to ask them, and so I'm going to quickly turn it over to Dr. Belushi to ask his impression clinically on this phenomenon we see.
Testing. Yeah, I agree with you, Chad. I've seen this effect as well. And as we talked about yesterday, I think it's as a result of the lung expanding and having a finite amount of space around the lung until there's good tissue apposition between the lung and the chest wall. And I personally think, and I'd like to hear from the audience their opinions. I personally think that our best hope for sealing an air leak is when we have apposition of the parietal pleura. If you don't have apposition on both sides of the staple line, you're going to have some tearing as the lung expands, and I think that's where you might see this increased air leak until that lung becomes opposed to the chest wall, and then you have a diminution of the air leak. And I've witnessed this particularly with emphysematous patients, because I think we all have experienced that situation where we don't see an air leak initially, the lung is inflated, they're taken off ventilation, and then they end up having a bigger air leak in the postoperative period. But I do think that that phenomenon does exist.
And as we have tried to dive into the literature to better understand this, that's a similar hypothesis on where we landed, especially based on some of the observation. When we look in the literature on gas distribution studies, and even our qualitative observations with atelectasis in these lungs, we see that there appears to be a difference in the ventilation with negative pressure. As that lung is expanding under negative pressure, we've also observed that the periphery appears to expand more under negative pressure. So we actually have some studies that we've done looking at the three-dimensional strain on the tissue. We can measure that in real time as the tissue is expanding, and we see for the same pressure differential, whether it's positive or negative pressure, about a 10 to 30% increase on the strain on the lung in the periphery. And even some of the lung volume reduction work from the early 90s hints at the negative pressure expanding the lung more, potentially worsening the leaks. But on the flip side, we know that as that lung expands, there's the chance of apposition, which will stop the leak. And so there's this balance between the negative pressure worsening the leak and the apposition stopping the leak.
So yeah, I agree. And our hope is that we can sort of try to characterize various types of leaks into categories that will help educate surgeons as to what we do at the time of surgery that cause these leaks, and then how we can avoid them. And I think this is an interesting project because I think that we have a model like this that we can practice on and sort of clearly demonstrate, this type of dissection leads to this type of air leak, and perhaps we can modify the way we use these devices, such as staples, to help reduce that would be helpful.
I'm glad you brought that up, because that's actually, for me, really exciting, is being able to talk to surgeons about how this model can be improved upon and how it can be utilized. And even as recent as 2 days ago, we were talking about how we can utilize this model from a training standpoint to guide different approaches surgically to reduce air leaks. And so I get excited because if we can help move the needle on this problem, that's a win. And so great thoughts. And I implore you that if there's an opportunity after this talk, if you have some good ideas, some good experiments, some good thoughts on this, please reach out to me, and I would love to hear more. We have a second study that I'll briefly touch on before we end. This one's also published. We recognize that the needle pricks aren't the only leaks you might see. Hopefully you don't see very much. And so we tried to simulate a wedge resection in forcing lungs, looking at variable thickness parenchyma. You can see a cross-section over airway. Really trying to challenge these staplers, looking at thick and thin tissue, and testing what are our hypotheses on staple design, graduated staple versus uniform staple, how the staple heights themselves might play a role. And this publication was also available under open access, guided by thoracic surgeons. We included Dr. Seth Force from Emory and Dr. Masahiro Sugoi from Tokyo on this, available for free download. So I encourage anyone that's interested to take a look. Very clear on upfront limitations. This is an acute model. These are healthy, young, worsening lungs. And we only looked at the staple line leaks. So they leaked elsewhere. Those lungs were removed from the study. It's one of the strengths of this model is that we can guide and pick out what leaks to track. We did not have apposition of the tissue. We didn't want to introduce a variable that isn't guaranteed in the operating room. And one of the really interesting observations that occurred in any of the leaks was that leaks occurred at the outermost staple row, the staple row furthest from the cut line. Not at the cut line, but the third staple row from that cut line. In every case that we saw a leak, it was in that row. You can see in the video playing. Most often it was in the thinner regions, but also did occur in some of the thicker regions. But all the time those leaks were in that outermost staple row. And more specifically, what we observed was that there was a difference, especially under the negative pressure, between the incidence and magnitude for graduated versus uniform staples. So we saw an almost double increase in the incidence of air leaks, the number of lungs that leaked with the graduated staples versus the uniform staples. And of those lungs that leaked, we saw more leak, a greater volume with the graduated staples. And you can see there's a faint dotted line on the screen which demarcates an inflection point where we see that where those values increase rapidly, and that's where we transition to the negative pressure. So negative pressure exacerbated that leak and actually exacerbated that difference in the leak between graduated and uniform staples. And we never want to present data without trying to understand hypotheses. So very quick, 2 hypotheses driven from the device design that we think is influencing the data in a leak standpoint. One is that if you're familiar with graduate staples, they all have, each row has a different height, whereas the uniform, by definition, don't. And what we see is that the tallest staple in the graduate design is the outer row, and that's where we saw the leaks. So we hypothesized that perhaps that taller staple isn't sufficient to compress the tissue to stop the leak from occurring. And what's interesting about this observation is that it's substantiated by another study that was published a few years ago, a little bit different model, actually looking at the same staple or brand, graduated versus, they call it non-graduated, uniform staples, looking at the pressure at which leak first occurred. With the positive pressure, we see that the graduated design actually had a lower pressure at which leak first occurred. It was less robust than the uniform staple line. They hypothesized the same thing. In the conclusion, they talk about the lung crank along that outer row, furthest from the cut line, possibly not being sufficient to compress the tissue. And the last tissue effect that I want to highlight is with compression, and how these devices compress tissue. My bias is that from a tissue mechanics standpoint, just as important as the staples we form is the way that we do that. And so if you're familiar with single stage versus multi-stage compression, if one compresses with a larger force initially, waits 15 seconds, and then compresses finally with fire, it's actually lower force on the tissue than if you compress with a light force and finally fire. And this is the second to last slide, for anyone in the room that has been asked to wait 15 seconds, this to me is key. Just by waiting 5 seconds on tissue, reduce the force by up to 2/3. And by waiting 15 seconds, you're down to about 1/5 the original force on the tissue. This is an effect called viscoelasticity, and it's a critical influencer of potential damage to the tissue. This is not only time dependent, but it's force dependent. So you have to have the right mix of initial compression on the device and time to get the desired response. And so we believe that perhaps some of the trauma observed in the tissue could be because of the differential how the devices form staples. And so finally, I want to end with where we're going next. This is what excites me. Everything I've shown has been human, or has been animal tissue, but our goal is to move this to human tissue. We hopefully by the end of the year, finalizing a contract with the university to utilize transplant-rejected human tissues. This will be living, diseased tissue from donors that are not suited for transplant. We'll be able to run them in our model, perfuse them, keep them alive for longer periods of time, and really start to tease out the effects that we observed in the pig tissue on diseased tissue. And as I said in the beginning, really begin new experiments influenced by what you, the surgeons and doctors, see as valuable. So I want to end with how I started, and that is that our goal is to try to drive towards better outcomes, better device design. And if anyone has an interest in learning more about this model, talking about experiments, and where we should be going, I'm happy to talk. Please reach out to anyone from Ethicon. We'll find me after the event. Thank you.
So in the interest of time, we'll do two Q&A. Mark, the first question is to you. Do you think that we already have good enough staplers, but just that because we're not applying them well, that's why the air leak happens? The second question is, what is your opinion on reinforced staplers? Thank you.
So the answer to your question is I think we have excellent staples. I think some staplers are better than others. And I do agree that there is an effect with graduating staplers that is not ideal. I've used all the different staplers over the years, and I do believe that, as Chad said, compression and time is very important. As far as using reinforced staples, there are certain risk factors that are likely going to lead a patient to have an increased risk, and I think reinforced staplers and sealants are adjuvants that would be helpful in that circumstance. But personally, I think the most influencing factor that causes an air leak is poor surgical practice. And I think a model like this can help us better understand what leads to those air leaks and how we can change our practice to reduce those.
Mark, thank you, Chad.
Thank you for the
Thank you.
opportunity.
Good night.